So one of the questions, just as the folks are coming up, one of the questions I received is what was the death from photodynamic therapy? It was unrelated to the treatment. It was just basically, I think somebody had an MI or a CVA or something like that that was deemed treatment non-related. But that was the death in the photodynamic arm.
Hey, Jim, while we're waiting on folks to get situated, I had some questions. Can I ask a question about the cryosurgery data?
He's sitting next to you. Ask him.
Yeah, I was, first of all, I'd just like to compliment you for taking the time to put together all the data, and it's obviously something that you're passionate about. One thing, the Phoenix definition, very few people actually have read the paper, the Phoenix definition paper. And in the paper, we make the point that the Phoenix definition, which actually was designed to replace the Astro definition. So we don't recommend using the Astro definition because it fails to follow certain statistical principles. But the Phoenix definition was not designed to demonstrate what your cure rate is. It was designed so that when we did trials that involved radiotherapy and we had hormone therapy on both arms, we wanted to be able to get early results in terms of, so it's for comparison of radiation arms to try to determine which arm is more successful than another. So the concern that I would have is that, I think, and this is not just specific to cryo, it's about any of these ablative therapies where we use a definition that's not actually designed to be used to be saying these people are disease-free. It was designed, and one of the points that was made in the talk I gave on brachytherapy is that when we do ablative therapies, the ablative therapies should result in the PSAs being at a very low level, which is what you showed, is that if the PSA didn't go to 0.4, then the patient's long-term had a very low control rate. So I would encourage you to, not just you, but the people that are doing work in this space of cryosurgery, to actually come up with a definition after cryo that would probably look at something like a value of 0.4 as an ablative modality if you're trying to determine what the long-term control rate would be, and discourage the use of the Phoenix definition for that sort of treatment.
First, I thank you for your kind comments, and we did review those papers and all the papers on different forms of failures. As I mentioned, the reviewer from Journal Urology, and actually the editor of the Journal Urology, insisted that on our first paper we put an undetectable rate, which we put in there, but we regard as meaningless. Actually, we've looked at the possibility of trying to declare that less than 0.4 nadir as potentially being a meaningful outcome. I don't think we have the data yet to say that definitively, but that's exactly where I kind of see we're likely to go. I'm just not ready to say that we can prove that yet, and we don't have a better one. And so our hypothesis in the original papers and ever since have been, we don't want to say this is success. We're going to give you data. We're going to draw some conclusions from that, but we didn't want to say that meant it was a successful treatment.
Dr. Crawford.
So, Steve, the great presentation on the cold registry, and I admire that you've taken that and kept it where it is. It's very important. Three things. One is, and this wasn't part of your talk, you didn't mention any of the immunological aspects of cryotherapy. What are your thoughts on that?
I think there's some intriguing studies out there that suggest that. In my heart, I believe there's some likelihood that they're true. We don't have in the registry any ability to address it, though.
Because I've seen some people that, and we're studying this right now, Glade, and I got some money for somebody to do it, and hopefully we'll have it. But we've seen people where we target it, like we've done a lot of targeted therapy, hundreds, that where you treat part of the prostate and you get involution in the rest of the gland. I mean, there's no reason. We didn't even treat that. I have no idea why that happened. Okay, that's number one. Number two is that there's all this interest in oligometastatic disease right now and doing radical prostatectomies, which I think is absolutely crazy. There are other ways to ablate the gland, and cryotherapy is so easy, and we've been doing that for since the first machine came out, we were the number 3. But what are your thoughts about that? Newly diagnosed metastatic disease, whatever, at some point treating the primary with cryo.
So we get in the opinion phase now, and so I agree that you're in other work. To your point, you were doing this before I even knew that it was a serious modality, and that I think that there is a high likelihood that those immunologic aspects are true, and I encourage to continue to work on it. As far as doing it in the oligometastatic setting, I as a practitioner, don't have data to suggest that I should do that. So just like with radical prostatectomy, I don't do that. I wouldn't criticize those that are, but I don't have data to support it.
So the last thing, Gloday's here, and Gloday's been sort of a thorn in my side, knife in my back, whatever about cryo since we got it. So he always says no data, nothing with salvage. So you've listened to Steve. What are your thoughts now?
Well, no, I think that since you started it, it's the early patients, as you know, had trouble, and I think that everybody in the field deserves a lot of credit for making it a lot safer and very acceptable. I think it's the treatment of choice for salvage, obviously. But I'm hoping that that the studies with the immunology and all that show improvement. As regards to ablating the prostate after somebody has metastatic disease, I'm very open to that. I think that the study in Nature that showed in the patients with phenotyping the patients with molecular markers that the cancer cells go to a lymph node, back to the prostate, then to a bone, and back to the prostate. And if you can eliminate 95% of the tumor volume, it strikes me, it would take a huge study to ever show that. But if you can do it with a relatively non-toxic approach, why wouldn't you? And I think it's something that really needs to be studied.
Yeah, we've done it on a number of people, as you well know. And we've even done some seeds, but it's interesting.
So there's a much larger body of literature using radiotherapy to stimulate the immune
That
system.
doesn't mean it's right.
I didn't say it was right.
There's
I
lots
just said
of
there's
bodies of radiotherapy
there's a much
and
larger
bodies, too.
body of literature with published and clinical trials that have been completed showing that dramatic responses to where you give local radiation to an area and induce responses to metastatic sites. So the idea of stimulating the immune system can be done with a number of modalities, and radiotherapy has been used. Could I ask one more question of the panel before you get to
Yeah,
please?
go ahead.
Yeah. That was a great
Now,
talk.
is it going to be preceded by about a 30-minute comment?
No, just
Okay,
10.
just ask the question.
Just 10. So that was a great talk on MRI. You covered everything except for one thing, and that was the role in the salvage setting. We talked about salvage therapy, and actually the way that I use it mostly in terms of salvage instead of doing cryo is we do brachytherapy salvage of recurrences after external beam radiation. You may have wanted to cover it and didn't have enough time, so I thought I'd ask you a question so you could tell us what your experience is in using it to do planning or using it to guide treatment in the salvage setting.
The short summary is we get it to help guide biopsies in the salvage setting to see if there's still cancer there, but we have not used it more than a handful of patients to actually guide the treatment if you're going to do some type of focal salvage therapy.
So we have data in the post-radiation MRI setting. Do we have data for cryotherapy and what kind of metabolic changes you get on MRI, or is that not something you capture in your database?
I hate to say data. We certainly have a ton of anecdote to a prior comment today, a ton of anecdote that you can see post-cryo recurrences. It's actually not any harder than the primary setting. To Mack's question, though, I always get an MRI on patients for salvage looking for incurable disease unless they've had brachytherapy, in which case the images aren't helpful.
Okay. And the other question that came up, just to finish off a little bit on cryotherapy, is are there any patients now that you do focal salvage based on the data that you showed that there really wasn't much difference?
I do, and I'm probably talking out of both sides of my mouth. So we have 111 patients from which to learn. None of the fistulas were in my hands. My own series of 10 or something like that actually have had pretty good outcomes, but I'm certainly not going to stand in front of a big group and say my 10 patients are going to change our treatment paradigm, but I still do it.
Okay. Any potency outcomes in those focal? I know whole gland it should be 0.
Interestingly, I think they're as good if they're potent pre-treatment, which most are not. If they're potent pre-treatment, actually, we've had a smattering of men who have totally normal erections afterwards. I have a great anecdotal series going.
Good. All right. So a couple of questions, just going through the list, and thanks for submitting your questions. The first is for Dr. Klotz, and it was regarding an older paper in your active surveillance series where at 5 years, about half of the men ended up undergoing either radical prostatectomy or radiation therapy, with changes in how you follow patients in terms of the PSA kinetics and perhaps limiting the percentage or the numbers of patients with Gleason 7 disease. Has the treatment rate gone down over time?
So early on, I mean, we used any patient who had a PSA doubling time less than 3 years got treated. And 44% in the publication of 2010, 44% of the patients who were treated just based on PSA kinetics. And I am sure that led to more patients being treated than needed to, because we also looked at what the PSA kinetics were in the stable population, and depending on how you calculate it, fully 50% of the stable, untreated patients either had a PSA velocity above 2 or PSA doubling time less than 3 years calculated a different way than we calculated. So it's just not reliable. So that explains a lot of the relatively high rate. And my impression is that the intervention is happening sooner now because they're getting MRIs and they're poor risk cancers or higher grade cancer being identified earlier. But I think the overall intervention rate has been relatively stable, somewhere around 40% at 5 years. And that's true of just about every single group. It's somewhere between 30 and 40%.
Okay. The next series there's a few questions about MRIs, so I'll just go through those. These will be for anyone on the panel. From the standpoint of MRI being done after either prior TURPs, patients on hormonal therapy, including 5-alpha reductase inhibitors, are the positive and negative predictive values still useful in those subsets? I guess that's for you, Scott.
Yeah. So the question is, can it be done after TURP or ARIs?
Is it useful?
The
I
answer
know
is-
it can be done.
Yeah.
Is
So
it
I was going to
useful?
say, yes, it can be done. I'm not aware of any data on the operating characteristics of how it works. After a TURP, I would wait significantly longer than the typical 6 to 8 weeks.
Okay. Any data in hormonal therapy? Laura, you had a study, I think it was out of your center, that used 5-alpha reductase inhibitors. It reduced the positive rebiopsy rate. Did you have MRIs in those patients?
No, that was kind of pre-MRI era. The REDEEM study was published about 5 years ago. It wasn't a great study because Gleason 6 volume progression beyond Epstein was considered a positive progression criteria. So, but the rate of progression, including volume progression, was reduced by 44%. Not surprising. We know that that low-grade cancer volume is probably going to decrease with 5-ARI. So, but 5-ARI does not significantly reduce the performance characteristics of T2 weighted image diffusion restriction, or DCE. It does change the spectroscopy.
Right.
And Mack knows more about this, but if you're not using spectroscopy, it still has the same performance characteristics.
Right. So one thing that our colleague here didn't talk about was the MR spectroscopy, which most people have abandoned because it takes longer to do, and it doesn't add a whole lot, but it does add a little bit if you go to the centers that have access to spectroscopy, where you measure choline citrate. And hormone therapy lowers those peaks on spectroscopy, so it interferes. And we did a study where we were looking to determine whether we could document activity of dutasteride and looking at cancer response in people that were on active surveillance. So we had baseline MRs that were perceived to be abnormal based on small areas of spectroscopy, and we gave them drug, and it was not very helpful because it lowered the citrate ratios, and generally speaking, we look at choline to citrate ratios as areas where there's cancer. So that in a sense, in some patients, it made it look like the cancer got bigger, and other patients, it looked like it got smaller. And so for patients with very early disease, we didn't find it to be terribly helpful. I think that there are opportunities in patients with more advanced disease to look at, whether you could evaluate drug activity in people with intact prostates. It could be relevant, but that's the only setting where I know that it really affects the interpretation of the study, is the spectroscopy part.
And I think this would also be for Scott. In the PROMISE trial, when they did the transperineal biopsy, was it every 5 millimeters a true mapping biopsy, or was it a zonal type sampling of the prostate? Do you know that offhand from that study?
I don't.
I think it was every centimeter.
Okay.
It wasn't zonal mapping. It was true template biopsy at 1 centimeter interval. 5 millimeters?
Okay. And from the standpoint of doing an MRI guided biopsy, do you have a bias towards cognitive fusion versus using one of the software platforms?
So on the available data, the value of fusion, I think, has been overplayed a little bit, and there's actually some studies out there that have compared cognitive. And for those that don't know the term cognitive, it's basically you do the MRI, the radiologist tells you, left base, medial, looks like it has a lesion, and you do your standard truss, and you just take some extra samples from there, and you don't have the side-by-side screen. And there's a few studies that show that works just as well as these fancy fusion technologies.
No, you're supposed to have the image in front of you. I mean, but it's not just the description. You should be looking at the image.
Should have looked at it at some point. You don't necessarily need it in front of you. Yeah.
5 millimeters, confirmed
Okay.
by Dr. Parton. They were done every 5 millimeters. So it was a true mapping biopsy in the PROMISE study.
But, in the ASSIST trial that I mentioned we finished recently, we used the Artemis device. And there was a learning curve with that device. And early on, we got some targeted biopsies that showed skeletal muscle. So that's a problem. If you're doing a targeted biopsy of a lesion and your needle's actually outside the prostate, your targeting device isn't working very well.
Okay. And this was just a general question about MR and the positive biopsy rate. Should MR studies be held to a whole mount or a biopsy confirmation? Scott, what are your thoughts?
We could have a whole panel on that. It depends what your outcome of interest in. Whole mount is more pure and true. You can make the argument if your whole mount shows a little sliver of pattern 4 that's meaningful, and there's a whole bunch of other people that say if you have a little ditzel of Gleason 4, maybe it's better you don't find it and just you do your transperineal or your truss. Speaking
as a radiation oncologist, we'll pass on the whole mount and just go with the biopsy as the standard to be compared to.
So you opt to use the inferior standard. Okay, thank you, Dr. Roach.
We don't need the whole. We don't need the whole mount.
I have this concern. I don't know if anyone else shares it, but if we're moving into the era of early MRI, then potentially we could be recapitulating the whole PSA fiasco, which is we do MRI, we find these small lesions on all kinds of patients, we biopsy them, we find 3+4, and boom, they have clinically significant cancer, and we're whacking out the prostate. And I'm concerned that the combination of MRI, small volume 3+4, may be a whole new kind of overdiagnosis phenomenon.
And see, I'm less concerned because at UCSF we've been doing MRIs for a long time, and you showed some studies that showed that people had negative MRIs and positive biopsies. We've known that a long time. Before those studies were done, we'd have people that had positive biopsies that come in, we get an MRI, it showed nothing. So rarely do I see some, as it was the point that was made, is that it underestimates the volume of disease. So we don't see, if you have a small cancer, it doesn't usually show up on MRI. It has a resolution issue. You may find it by accident, which is going to happen because your needle goes in there, but you have to have a certain size lesion for the MRI to pick it up.
Okay. Last couple of questions, of course, the best for last for Dr. Roach. Do you think the 5-fraction radiation, the cyberknife type of radiation therapy, has that contributed to the decline in brachytherapy?
I think it has contributed to the decline in brachytherapy, and we just don't have great data. So the stereotactic body radiotherapy, which is the sort of the generic term for that kind of treatment, where you treat a patient definitively with 4 to 5 fractions. The first paper was published about 2007 with very short follow-up, mostly a toxicity study. So most of the studies now have results that go out about 8 years. And so if you can put 3 or 4 gold marker seeds in a patient and then give them 4 or 5 fractions, and the morbidity is not real high, the PSA responses appear to be impressive. I think that certainly is appealing. We don't have long-term data. The morbidity does appear to be slightly greater, but I think that there's some tweaking in terms of what dose constraints you set, and it has had an impact not only on brachytherapy, but also IMRT. I think it's going to and also threaten proton beam radiation. Why should somebody, have 40 treatments with protons if they can have 4 or 5 treatments with SBRT? So it remains to be seen long term how good it is, but it's encouraging so far.
And the final was also for you, Mack, is in terms of, at least with radical prostatectomy, surgeon and surgical technique has been shown to impact all the outcomes. Has that been shown in brachytherapy as well, in terms specifically of toxicity, but also in oncologic outcomes?
Well, we have dosimetric parameters that have been shown to correlate with outcome, so that if you don't cover if your implant isn't very good, then you tend to have very high recurrence rates. And the problem with the literature in brachytherapy is the people that tend to publish papers on brachytherapy know how to implant the prostate. And the same thing happens with radical prostatectomy. You have, 2% of surgeons are high-volume surgeons, and those are the ones that publish the papers, and yet it's the low-volume surgeons that are quoting the results of the high-volume surgeons. So it's clear that the quality of the implant's important. There are also data looking at outcomes with radiotherapy based on volume, and it does suggest that expertise is important with radiotherapy, although I think it's less doer-dependent, especially when you do something like CyberKnife.
Okay. And in the interest of time, I'll ask one more question. Cryotherapy, it fails. How do you manage the failure? We have surgeons, cryotherapists, and radiation oncologists. I'll start with Lori.
I don't see cryotherapy failures because I don't see cryotherapy. It's kind of doesn't really exist in Canada. But I think, there's other minimally invasive approaches, HIFU, for example, which we've been doing for quite a while, and I think is going to become much more popular in this country now that it's approved. And radiation's probably an option, salvage radiation post-cryo, and surgery.